Hello and welcome to our Permanente live webinar, The Revolution and Evolution of Acute Care at Home. I'm Dr. Stephen Prodi, Executive Vice President with the Permanente Federation and Associate Executive Director with the Permanente Medical Group. And I'm pleased to serve as your moderator for today for what I expect to be an insightful dive into advanced care at home. Advanced care at home, which is sometimes referred to as hospital at home, is the ability of health systems to provide acute level care services in a patient's home, where they feel comfortable and supported by family and loved ones. The current COVID-19 public health emergency gave systems the ability to do so with the flexibilities to accelerate these advanced care at home programs. And today we are going to learn a lot more from our panelists about how these programs will evolve post-pandemic, the future clinical roles that could be created, and how these programs can be expanded on a much larger scale. We'll have a Q&A session at the end, and you are invited to submit your questions using the Q&A function on Zoom. So let's dive in. First of all, I'm pleased to welcome our esteemed group of physician leaders from across the country from a variety of healthcare organizations. First of all, we have Dr. Mary Giswald, who is the Chief Operating Officer of Northwest Permanente, which provides care to Kaiser Permanente members in Oregon and in Southwestern Washington State. She is a general surgeon, and her leadership role has included serving as Associate Medical Director for Hospitals and Post-Acute Care, where she has had oversight over Kaiser Permanente's regional KP Care at Home program. Secondly, we are joined by Dr. David Levine, who is a practicing general internist and clinician investigator at Brigham Health and Harvard Medical School. He serves as the Medical Director of Strategy and Innovation at Brigham and the Brigham Health Home Hospital, and is the co-chair of its Hospital at Home Users Group. Thirdly, we are joined by Dr. Michael Maniaci, who is the Enterprise Physician Lead for the Advanced Care at Home program and Medical Director of the Mayo Clinic Hospital in Florida. And lastly, we're joined by Dr. Sarita Mohanty, who is the President and Chief Executive Officer of the SCAN Foundation, one of the largest foundations in the United States focused on improving quality of health and life for older adults. Thank you all for being here with us today. So Sarita, I'd like to go ahead and start with you and ask sort of a big picture question. So coming out of the pandemic, what has changed about what people want from healthcare in general?
Well, thank you, Dr. Parodi. I really appreciate being here today and participating with this esteemed panel. First, I'd like to say that the COVID-19 pandemic offered us some real key learnings on how to care for older adults. A lot of them have complex needs, and we learned that these individuals want us to first simplify a somewhat broken, complex system. For those with complex needs, majority of whom are older adults, the system is often difficult to navigate. And older adults, just to remind everyone, are the fastest growing segment of our population. By 2035, we will have more adults than children in this country. So for the sake of this expanding demographic, we really do need to have a system that is simpler, easier to access, and less fragmented. Second, the pandemic taught us that we must drive to true care coordination or coordination of care. And in this current landscape, we often see, particularly for those with complex needs, this patchwork of disparate, confusing, often uncoordinated sets of services and providers, particularly, as again, with those with complex needs. And the flexibilities that came out during the pandemic attempted to connect services and supports to individuals in the home. So now with these complex, those with complex needs are expecting to continue to have this connection of services in their homes. So that is another important thing as we think about care coordination. And third, we learned that we need to maintain a relentless focus on the individual during the pandemic. The SCAN Foundation, where I work, believes that a person's health care and social support should support support a person's life goals at any age. And in 2016, we actually defined person-centered care as care where a person's preferences and values guide all aspects of their health, not just medical, but social and behavioral. And during the pandemic, we saw that Medicare and Medicaid programs work swiftly. And these programs don't often work traditionally moving that fast, but they made adaptations, again, under the public health emergency to support person-centered care. And so as a result, care delivery moved more into people's homes. And this hospital at home model, or advanced care model that we'll be hearing more about today, I think can really serve as a foundation for furthering person-centered care. And the last thing I'll just say is that we really need to ask with the conversation, what do people want? What are your preferences? And I do like to highlight that in order to structure the conversation better, one thing we learned is that we need to ask person-driven quality measures or outcome measures. And the National Committee for Quality Assurance has continued to advance the development of these PDO measures. And we've actually seen 13 states and Kaiser Permanente included piloting these measures. And I think that is really adds to kind of the emphasis to all of this. What do people expect from healthcare? We need to ask them. So that would be one of my core takeaways from what we've learned from the pandemic and what we need to think about going forward.
Well, thank you, Sarita. And you're referencing massive demographic change in the United States, not just now, but I think what you're saying is into the future. So Mary, could you talk to us a little bit about both the expectations of care as well as the changing demographics, and tell us a little bit about the advanced care at home program that you helped launch at Kaiser Permanente in the Northwest, and how you see it meeting the needs of our patients in a person-centered way.
Thanks a lot, Steve. Also very honored to be here today and to talk about our program. We call our program Kaiser Permanente at Home. Over the last 2 years, we've learned that we can care for inpatient level acuity patients and provide high quality care that is person-centered. We admit patients from our emergency departments and our med-surg units with pneumonia, CHF, cellulitis, COVID-19, and now even some post-op patients. We started really small in April of 2020 at the beginning of the pandemic, and now are carrying an average daily census of about 15 patients. We admit about 3 patients per day. We're offering this to clinically appropriate patients across our Oregon and Southwest Washington region. And all the patient needs to have is running water and electricity. We provide everything else: internet, redundant connections to the command center, medically tailored meals, therapies, and caregivers. And we also find that being in the home, virtually and physically, allows a real in-depth understanding of the social needs of our patients. It increases that opportunity to connect with patients and their families so that we can address social needs and connect them to community resources. And then also, as an integrated system, the program, we think, also will bring value to our members, because as these programs scale, they potentially will offer more affordable options for hospitalization than building brick and mortar facilities.
So there's a lot there, and I'm sure we're going to dive into more. I'm going to pivot to Mike, and Mike, talk to me a little bit about Mayo and what you've all been up to.
Yeah, well, our program mimics KP's program in the virtual hybrid model, having a command center with the bedside nurse and rounding physician in a virtual sense, combined with in-person supply chain resources, rounding APPs, APRNs, infusion nurses, and such in the home, delivering the care that we're implementing. We have our command center in Florida, in Jacksonville. Through that command center, we see patients across 3 states. We see them around in the Jacksonville area, in Northwest Wisconsin and Eau Claire, and in Phoenix, Arizona. We started with Florida and Wisconsin in 2020 when our program first started in July, and expanded to Phoenix, Arizona last year. We've seen over 800 patients over the last year and a half in our program. We carry a census of about 15 acute patients and about 35 restorative patients. That restorative phase is owning the patient after the acute hospitalization for up to 30 days afterwards to complete their care with education, getting them in tune with resources, escalating care if need be, and passing on to their primary care provider in a smooth handoff. How it meets the needs of our patients, really, I usually sum it up in 3 words: safe, happy, cheap. Safe, providing top-notch care that's both safe and high quality, that is equivalent to, if not better than, the brick and mortar hospital. Happy, we want to give the best experience to our patients, to the caregivers and family at home, and also our providers that are providing this type of care. And then cheap, we want to save money for the patient. We want to pass it on to the system. We want to drive down the costs associated with multi-billion-dollar buildings and the care we give today. The problem with care today is, things are so centralized and they cost so much to provide that care. Decentralizing this care and spreading the community, we hope really impacts these needs of our patients and expands our reach at Mayo and at other institutions as well.
Well, thanks, Mike and Mary. So, David, I've heard the oft sort of repeated phrase that if you've seen one hospital at home program, you've seen one hospital at home program. And there seems to be confusion on what we're talking about when it comes to advanced care at home. Can you sort of talk a little bit about how you define it, and how should we be looking at it, that, as an entire sort of health system or industry when it comes to healthcare?
Yeah, thanks, Steve. It's a great question. And I would broaden the phrase to, you've seen one ICU and you've only seen one ICU as well, right? We all work at different institutions across the country, and guaranteed we have really different practices, even though we're all doing medicine. It's kind of mind-blowing, but I've been privileged to train at several places. And it's almost mind-blowing when you get to a new institution and you say, that's how you do it here? And so I think, because it's a very nascent field in some respects, and we're seeing pretty explosive growth of home hospital right now, we have a lot of great variability in how we practice it. And in some respects, that's going to remain. That's kind of the American way. And in other respects, I think we're going to learn and iterate kind of what's more efficient, less efficient, which kinds of patients can get care in certain ways. And so the best way I like to look at home hospitals, really, it's care that would normally have been delivered in the hospital's walls. And it's really associated with that community provision of care as a substitute for traditional acute inpatient care. And oftentimes easier to think about what it's not. I often like to kind of say it's not home health. People often call my program, as I'm sure they've called Mike and Mary, your programs, oh, it's the home health team. No, it's not. Home health has been around for decades. It's a certified Medicare benefit, and this is not home health. It's not home infusion either, right? We have a great home infusion teams in the community already. It's not home hospice. People will sometimes conflate the two. And it's not home-based primary care, right? It's not chronic care in the home. So it's home hospital, or it's that acute care delivered at home, which I think really makes it a different kind of delivery that can enmesh itself really beautifully with other home-based care services. And I'm sure, does in many of the people's programs on this call, and I know does across the country. But it's definitely that acute care. You have to imagine that patient would have been in your hospital's, in your hospital bed if your program didn't exist.
Yeah, thank you, David. I appreciate that. Sarita, I got a question for you. So if you think about hospital at home programs in the context of what we've just heard, how do you see social determinants of health being weaved in? What does that look like from your perspective?
Yeah, it's such an important question. And I'd like to first off say that in 2022, I think it's important to recognize that we are seeing, these inequities in care and how care is delivered, particularly affecting Black, Brown, Indigenous communities, low-income populations, those with disability, rural populations. And there's a lot of misalignment of financial incentives and policies to achieve what I described earlier, person-centered care, which includes addressing what you mentioned, the social determinants of health, these upstream factors, like shelter, food, financial stability, so that older adults who need supports and services can receive that kind of care in their home and their communities. And, hospital at home programs are, I feel, uniquely positioned to address social determinants of health issues because they're personalized care models based on the person's needs and particular experiences, throughout their life. And Dr. Giswald highlighted that during her comments as well in terms of their program addressing the social needs, social determinants of health. You know, if you think about it, at the acute hospital at home, transportation burdens are lessened, less time off for family members who can now see their loved ones in the home versus having to visit a hospital setting. You know, you have safe living and family support, and even if you can do assessments on things like food security. You know, do they have adequate food in the home to help them, sustained to help them heal? You know, one statistic, 16.3, I heard that 16.3% of Californians, for example, over age 60 are food insecure. So we have an opportunity to, really look at this more carefully. You know, the most kind of meaningful ways to help vulnerable populations close these kind of health equity gaps is to deliver solutions that connect members. Again, when we want to address social determinants of health, to community organizations and resources that can help them address these issues directly. You know, so assessing at the onset of care, regular intervals during the person's course while they're at home, getting these services would be really critical. Providing supportive care plans that incorporate and involve the community-based organizations in the care planning, of these individuals, and even partnerships using maybe community health workers that help, we've seen this, help coordinate and navigate access to non-medical social services so they can get those supports is also and really important, because we're in the community, we're these individuals in their home, their community, so there are services that could be available to them. And then last thing I'll just say is it's important to measure the impact and outcomes of the hospital at home models on vulnerable subpopulations. You know, we are, for example, are we seeing differences in access to the hospital at home programs across racial ethnic groups? What about those in rural communities? Are we able to avail them the same level of access to these type of programs? So we must ensure that, it is provided to all who are eligible. And we don't want to make disparities and inequities worse by instituting these important models. And I would say, as we work to scale these models, we got to be mindful, again, not just of the clinical, but the social and behavioral factors that really influence one's total health.
Thank you, Sarita. Those are really important points. And Mary, I want to turn to you and dovetail a little bit on what Sarita's talking about. And I know that Kaiser Permanente has been looking at who's getting admitted into the program and looking at from a neighborhood deprivation index scoring perspective. It'd be interesting to hear your perspective on that. And as you're looking to the future, what are you looking for in terms of being able to scale the program? What's it going to take to grow beyond the census that you were talking about? And in getting into that disparity question that Sarita was raising, which I think is really important, like how do we get into other areas, suburban areas, rural areas? What is possible with this program?
Thanks, Steve. So it's when we started building this program, we had concerns about how do we make sure that we are offering this in an equitable way. And so started tracking information, tracking that neighborhood deprivation index of the population of patients we were admitting to our program, because we wanted to make sure that this was available to all patients, regardless of what they had for, in their home in terms of resources. And fortunately, we have been able to show that we've been able to offer this program equally across, all spans of the neighborhood deprivation index. And I think one other thing, and you and I have talked about this before, about concerns about, well, are we shifting work onto the family away from the care team in the hospital? And really, if people want to be in this program and they need help in their home, we bring the caregivers into their home for them so that it's not an additional burden on their family. And I think it's thinking through those types of complex issues that are really going to be necessary to scale these programs broadly. And, so we have to get creative in thinking about what will we bring into the home in order to be inclusive of all of our patients. And then, around scaling, in Oregon and Washington have the lowest beds per 1,000 in the country. So during the pandemic, we admitted over 1,200 patients to our program, which created bed capacity for other people. And in Oregon, for example, we had during Delta, Southern Oregon was hit very hard by Delta. And we do not have a lot of bed capacity down there in the more rural parts of the state. But what it did allow was we were able to put patients in our Portland metro area who were willing into this program. We created bed capacity in the metro area so that patients, who needed higher level of care transfers could be cared for in the Portland metro area. But I do think, we are starting to experiment with bringing this program to more rural areas of our service delivery area, down into Salem, Oregon, and areas that have that are further away from the metro area. And certainly it can be done. It takes some creative problem solving with our supply chain partners. But as long as, it just requires a lot of infrastructure and planning, but I think it's possible. And the other thing I would say about scaling is that this does allow for a more flexible creation of hospital beds than building brick and mortar. In the Portland metro area, we now have multiple health systems who are creating these programs, because we are really underbedded in our area. And we can do this a lot faster than someone can go through a certificate of need process, actually build construction these days. It's astronomical, the building costs. So on some level, if we can figure out how to do this across entire communities, we're going to be able to provide more value to our patients and pass that on to the patients. The other thing that I think is really critical to scaling is finding a regulatory path as we start coming out of the PHE. We need to have a regulatory framework for how these patients are built, how these programs are built, what the quality metrics our programs should be tracking, so that we have so that we know that the programs that we are offering to the community are appropriately resourced, they're safe, they provide that patient-centered care that we're all talking about here today.
Thank you, Mary. And Mike, now I may be understating this, so you correct me here, but I know that you're operating, I believe, in 3 states now. You've scaled from, a program that was quote unquote local to now you're managing multiple sites. How has that evolved? What does that look like from your perspective?
Sure. So, it happened in stages. Stage 1 in 2020 was the pilot, clinical efficiency, satisfaction of the staff and the patients, economic feasibility. Can we do it? Can we turn it on and make it work? Start in Florida, make it work in Florida. Okay, the next month, can we turn it on in a different state like Wisconsin and do the same thing? Take 1 or 2 patients at a time, make sure that patient's safe, make sure the care being delivered is proper, then start to expand as we get comfortable with the model and the workflows. The next year, 2021, was about scale. Let's add new patients by adding new diagnosis, new sites, grow the numbers, new payers, try to expand and scale what we have with the program we have. And then this year is really doing some of the things that Dr. Giswald just said, looking at a national payer network. What is the regulatory framework of this, both at the federal level and in the state level, because all the rules are different everywhere, and establishing those quality metrics, getting down to the hospital users, a home group, and saying, okay, we know what to do for a brick and mortar hospital for quality metrics. How does that pertain to hospital at home and all the programs that are out there? How do we build this properly to look at the right metrics and feed that back to CMS and the commercial payers and everybody else? How do we build this focused around the patient, not around things that other people think we should be looking at, which aren't the right ways to do things at times? And then what do we build in that regulatory environment? How does JCO come in? How does ACA come in? How does that pertain to the home setting? So that's what we're going to have to look at as a team. That's why we built this coalition together, to say, hey, how do we do this from a medical standpoint to keep our patients safe and happy?
So David, I see some questions coming in through the chat. We're a panel of physicians, but the care team is much broader than that when it comes to advanced care at home. Can you talk to me a little bit about, what the teams look like now, what the teams might look like in the future? I heard some references to command centers, but there's like, who are the hands and ears and eyes and people that are seeing the patients in their homes themselves? Can you talk a little bit about that?
Yeah, absolutely, Steve. And I'll just go back to the original comment that you've only seen, one home hospital. You've really only seen one, because the teams are all different. I think there's some congruencies about them. But I think some models, as you've heard Mary and Mike talk about, do have a kind of a command center approach. There are other models that don't, and really take much more of a decentralized approach. Kind of, we don't even want the centralization of a command center. We want to distribute that even to like a local team potentially. And so I think we're seeing a bunch of different central, decentralized models. And then in terms of the care team, I think the core care team is very similar to the hospital, right? These patients need acute care. And so what do they need? They need a doctor, they need a nurse, they need the entire kind of care team that we wrap around those patients. And so maybe that's physical therapy, occupational therapy, social work, speech language pathologists, all sorts of different care team members who we can bring in as needed for that patient's care. I think when we started almost 7 years ago or 8 years ago doing this, we were a doc and a nurse, and that was about it. And obviously we need more folks as we get more complex, more different kinds of care that we're delivering in the home. We need to bring in consultants. We need to bring in surgical colleagues. We need to bring in all sorts of different folks. And so some of those people, we can do that virtually by video. Other people need to be physically present in the home. And so I do think the real core team, again, it changes. There are some programs that have only paramedics in the home. There are some programs that have only nurses in the home. There are some programs that have hybrids of nurses and paramedics and medical assistants and different kinds of home health aides in the home. And it's really just like we've been talking about, it's getting the right care to the right patient at the right time. And there are some patients who need 2 nurse visits every day. There are some patients that need a nurse and a paramedic visit. There are some patients that need that home health aide to be pushed into their home overnight for 12 hours so they can walk with them to the bathroom and maybe heat them up a cup of soup or something of that sort. And so it's really tailoring those pieces. And what's beautiful about home hospital is that, just like Mary said, it's very agile, right? We have the team members, we can push them in and pull them out as we need to. We don't have, this fixed cost of a bed that we need to fill. And so instead we can kind of push and pull the right resources. But I think core team is really a doctor and a nurse often, with then kind of supplementing paramedicine, supplementing all of our other specialists and consultants that we bring in, just as we do in the hospital.
Well, thank you, David. And we're getting a ton of questions coming in from the audience. So thank you for that engagement. And before we dive in, we want to actually ask you a question about what you think the potential benefits of advanced care at home programs are. So you're going to see a pop-up come up, and please select the answer to that question. And I can see the poll has just popped up. So we're just going to give you a second to fill that in. So while people are voting, I do want to sort of pose a question, because I'm seeing a number of these chat questions. So one's going to be sort of patient-centered, and then the other is going to be actually more provider-centered. And maybe the first question here is, I'm going to toss it to Mary and Mike to start with here. Talk to me a little bit about patient selection criteria. So how do you identify people? And is this an opt-in, opt-out process? What kind of agency or decision-making does the patient have? Does the on-site team have, where you're recruiting the patients from? Talk to us a little bit about that.
Yeah, Steve, I'll jump in here first. So one of the first, yes, we have fairly robust clinical criteria, but one of the first things we ask is if a patient is interested in being in this program. So, Of course, we want patient and family consent, and that they feel comfortable, that they feel like this is going to work for them. So all patients, have an opt-in, opt-out. And then as far as clinical criteria, we started really small with just a handful of diagnoses. And as we got good at that, we were able to expand more, understanding, what we could manage in the home. And now, we offer this to a wide variety of diagnoses. And, and really the main things that we kind of think about this as, how do we bring almost everything a med-surg patient would need, to their home instead of to the bed in the hospital room. So, obviously if somebody's going to need another 12 hours of observation and maybe for another troponin, or maybe they're going to need a procedure, certainly they're going to stay in the hospital and get those things done. But maybe 12 hours later, they could come into the program if the patient wants it. So we have now really expanded our criteria. We're starting to admit some post-surgical patients into the program. We've had about 10 patients who've had colon resections go either from the recovery room or early post-op day 1 into the program. And I think we'll find more opportunities in that space as well.
Yeah.
So I'll turn it over to you, Mike.
Yeah, sure. So again, just to echo off that, it's totally an optional, both for our ED patients and our tower patients to opt in or opt out of the program if available. We first rule them in or out by geography. We have certain geography that we go to. If they're outside that geography, we cannot provide the services safely at a quick time that responds to all the questions about how do we get, you have these rapid response services. You want to get to the patient very quickly if something does deteriorate. So there's a geography rule in, rule out. Right now, there's a payer source rule in, rule out. Most of our patients are Medicare, Medicaid through the waiver. And then there's a clinical criteria, not only diagnosis, but clinical stability. How is this patient doing? Do they need rapid services? Do they need ICU services? Do they need surgeries or procedures or advanced imaging? Those patients aren't ideal, at least at that time, for the program, because we want to have them clinically stable. Then we do a social screening that's advanced questions on what is the environment that they live in at the home? Who's at the home with them? Is it safe for them to get care at their home? Is it safe for our providers to go in the home? Are there guns? Are there weapons? Are there 30 cats that are going to lick the wounds? What are the things going on? Not that these will absolutely rule them in and out, but it will tell us what is the social situation. And then we make a discussion and informed consent with the patient. Hey, this is the care we can provide. This is the environment you want to provide it in. And we build that relationship together and proceed if the patient agrees to it.
So David, talk to me a little bit about, we were touching on who the care team is. What are advanced care at home teams, or I guess, what's the state of the art in terms of measuring satisfaction from the standpoint of the providers that are doing the care? So there's like what the patients are perceiving, and we can talk a little bit about that from an HCAP standpoint. I'm curious, given this age of needing to retain staffing shortages, what kind of satisfaction are we seeing with the programs?
On the behalf of the clinicians?
On the provider, clinician side of things.
Yeah, absolutely. I think, we actually published a preliminary analysis of burnout among our home hospital staff during our pilot. Very, very small study, needs to be funded and replicated. So all the funders on the call should give Mary, Mike, and myself a lot of money to study that. But I think the take home generally is that it's an extremely, extremely authentic way of practicing your trade and your craft. And most folks who taste practicing care in home hospitals often say, I'm not going back. And this is how I want to continue to deliver care to my patients. There are several great surveys that some programs are using right now across the country. For example, there's the Mini-Z Burnout survey to assess clinician burnout as months, years go by. But I think it is a really, there's a ton of open areas for research. My colleagues and I actually just published a research agenda for home hospital just last month. And that is one of the areas that we don't have enough information about clinicians' perception of the care that they deliver, other than a couple small pilot studies right now. Anecdotally, I can tell you that retention as well as satisfaction with care is quite high. Personally in my program, as I know in several others, but I think we have more work to do to continue to measure that. But frankly, we have work to do to measure that in our hospitals as well.
Those are great points. And I want to pivot here. Sarita, I've got a question for you that came in here. And this is highly relevant today. You were referencing the connections between health systems, public health, and then, of course, community health. And that really got supercharged during the pandemic. There's infrastructure that needs to be put in place to make that happen. There's interoperability questions between electronic health records and other records that are being kept on behalf of what we call patients, but others call clients. And I've heard some murmurings about what that kind of might look like. You've got an example here of advanced care at home, hospital level care, where we now have an opportunity to not only see into our patients' homes, but understand what their needs might be. What do you think needs to come next? Are there regulations that need to change? Is there the industry push to make that happen? What's that look like from your perspective?
Yeah, we are, it's a really important question. We are seeing, and, I think all of us are seeing that this, this push towards, connectivity across the different members of the interdisciplinary team, right? So we talk, it's been referenced, the teams, often it's a physician and a nurse, but then, depending on what the individual needs or wants or prefers, they may need supports on the social side, on the behavioral health side, mental health, things of that nature. And right now there is a big push to think about incentives to support that connectivity and make it easier. And we're seeing systems emerging where, for example, clinical systems are trying to connect with community-based organizations more effectively and efficiently. These platforms that allow, being able to look up resources and then refer patients, individuals to those services and make sure that services are received. And in this case, you would want to be able to ensure that services can be, given in the homes while they're healing. So definitely, and then a lot of value-based payment models, I think, are emerging to try to incentivize the healthcare team, the healthcare environment to actually offer, to partner more effectively, I should say, or coordinate more effectively with such type of services. A great example is in California. We have a new Medicaid waiver out called CalAIM, which is really focused on something called community supports. And this is actually a part of the waiver Medi-Cal package and relevant to, let's say, dual eligibles who have both Medicare and Medicaid to be able to, there's incentives for health plans in this case to offer these community supports like meals, like grab bars, or any other things that may be needed on the social side to provide what we call this whole person care. So definitely seeing a lot of movement on the, and the other thing I should also mention, there's something that, and Medicare Advantage plans have also been incented to do. There's something called Supplemental Service Benefits for the Chronically Ill, or SSBCI, which was allowing Medicare Advantage plans to actually offer these non-medical social benefits to provide to individuals. And that's another way to, so it's, again, these incentives are going to be very important to offer this connectivity across the systems. And I think we have a lot of work ahead, but I think a lot we learned a lot during the pandemic. So I think it accelerated some of the pace of these opportunities.
Thank you, Sarita. So Sarita was referencing a number of different programs, some of which are value-based. Mike, I'm going to throw you a hardball here. So, they just dropped some legislation in both the House and Senate to, move beyond just the public health emergency when it comes to advanced care at home programs. And some of the questions that are coming in are relative to, how is this program going to be able to continue? What does that regulatory framework kind of need to look like? Is it just value-based? Is it just Medicare Advantage? Can this be done in Medicare fee-for-service setting? Can it be done in other fee-for-service settings? What do you think, Mike?
It's a wonderful question, and I'll defer to others as well to throw in their ideas. I mean, from my standpoint, I hate thinking about payments, although we have to think about payments. I always say, do what's right for the patient, and the quality metrics and payment would follow that. The money follows that if you're doing what's right. So how do we build these programs? What's the right way to do this? Is it truly kind of a bundled, okay, what does it cost normally for a hospital stay, post-recovery SNF, remote patient monitoring and care afterwards, multiple visits and readmissions, and taking a fraction of that, using that as a bundle payment and owning patients. And we longitudinally own people, not even when they're at their sickest at these advanced hospital at home programs, but how that tiers into remote patient monitoring with supply chain resources, virtual care from a primary care provider and other consulting staff. If we build this longitudinal ownership of patients through our institutions, share resources in order to keep costs down, I think that's a payment model that both commercial and government payers can get after. Do what's right for the patient, keep them out of the hospital, keep them healthy, drive down costs. And that's what we should be reimbursed for, not just the quantity, but the quality of care we give. And I'll happily defer to others because I know they've dealt with this much more intensely as well.
Mary, I know you've been having to live the world of waivers and not having it done through a waiver. What's your sense of things?
Under the current waiver, it really, the current waiver has patients, where we can admit them out of emergency departments and the med-surg units under the current ACA waiver. And, I understand there were reasons that waiver was written that way, but for a fully integrated healthcare system like ours in Kaiser Permanente, and probably for other systems too, it really, I think we can move this further upstream. And we are starting now in our Southwest Washington area to admit patients directly out of urgent cares and clinics. And, it saves the patients the hassle, the discomfort, the pain of going to an emergency department just to check a regulatory box to then be admitted to their home. Our physicians are seeing, our physicians in the urgent care are assessing the patient, or in the clinic assessing the patient, determining they needed to be admitted to the hospital. And then through our transfer center, we can have conversations about, could this patient go, be admitted directly into their home? Of course, if the patient's, and their family want to go that route and it's clinically appropriate, then we can admit them directly to their home. So I think that really could help the ED utilization, the traffic through the emergency department, so that we can really focus in the emergency department on those, very critically ill patients who need very timely care.
David, I'm going to pivot us a little bit here. So, when I look at what the requirements were under the Hospital Without Walls waiver, from a quality metrics perspective or safety perspective, they were pretty limited. You've been looking at this a long time. You've been studying it a long time. What framework do we need to develop from a quality perspective, a safety perspective? Where are we at now? Where do you think we need to be heading?
Yeah, it's a great question. And what I will say, Steve, is the acute hospital care at home waiver, which is distinct from the Hospital Without Walls set of rules, is pretty novel in the sense that it obviously requires patient level reporting on 3 specific quality measures. And I think it tried to strike the balance during a pandemic of, we need to make sure that people are doing great care and at the same time not overburden systems with too much quality reporting. I think it probably struck that balance pretty well. And as you mentioned, really exciting, there's legislation right now in the House and Senate to essentially extend this waiver for 2 years so that more systems can get experience with this. We can get more data, see how these programs exist outside of pandemic type situations. And I am extremely enthusiastic about that. And I know there's an enormous coalition who is, enthusiastic about that legislation. The quality metric side of things, we've actually presented several webinars of this in the hospital home users group. And right now in the users group, we have an entire set of quality metrics that all of the users from around the country and Canada have essentially helped to create together. And that's going to form an entire national network where systems will have the opportunity to report in and to start to benchmark themselves on that quality, much as what is done by other groups around the country for hospital care, for palliative care, for different kinds of care at home. The home-based primary care teams have similar benchmarks and networks of data collection. And so these are measures, some of the obvious ones like unanticipated mortality, what we call escalation, or a patient has to go back to the hospital for an overnight stay for more advanced care. And then just kind of some unique novel ones, right, that really get to the patient experience piece about days at home, right? Like how many days at home are patients spending when they're on this program after the time that they're discharged from it? And so I think, we have essentially devised several of these metrics that we're recommending. And we have a bunch of enthusiastic programs around the country who kind of want to start to self-report on those. And I think we'll see CMS start to write some additional rules, sub-regulatory guidance around additional metrics that we want to start looking at. But I definitely don't want us to, I'm not a fan of, we need hundreds and hundreds of quality measures to deliver good care. I think we need to measure the right things for our patients. And honestly, I think CMS started in a very reasonable place by requesting unanticipated mortality and escalation. I think that was very reasonable. Should there be some additional ones that we want to measure in the future? Yeah. And, lots of folks have written about those. And now we have kind of a minimum data set that we're recommending through the hospital home users group. I think moving forward, it's going to be great to start to get now kind of, hopefully we can have 2 more years of this. So we have some really great data from across the country.
Mike, you referenced earlier this phrase restorative care. Can you build on that a little bit? Because I'm seeing some questions about, okay, you admit somebody into an advanced care at home program, you take care of their acute care needs. What happens afterwards? How do you make a determination somebody A is ready for discharge? And then B, what happens after discharge? So talk a little bit about that.
Sure. So I'm a hospitalist for many years, and I own you in the hospital and get you better, and then I release you into the world, discharge you, and I hope that you make your follow-up appointments. I hope you get your medications. I hope you go to physical therapy. I hope things go well. Occasionally I get a phone call, but I really don't know what happens. With this program, because you're already in the home during the acute phase, which is equivalent to your inpatient brick and mortar hospital stay, we get you better. You meet discharge criteria just as you would being sent home from a regular physical hospital. But then we don't take away the technology. We don't take away anything else. We keep those resources there for communication. We check on you, not as frequently as we do with 2 in-person visits a day, multiple virtual visits a day, like we do in the acute phase. But in this restorative phase, it's really owned by our nurses and our nurse practitioners, checking on the patient, answering questions, making sure they make the follow-up appointments, escalating care if needed, really owning you after the fact and bringing me in as I need it when new questions come up, when the patient needs to talk to their doctor, when I need to convey messages to their primary care provider or specialist, or just to make sure that if a new problem comes up, we can handle it right there and then, as opposed to having them come back to the clinic or hospital. I finally get ownership of people past the hospital stay. And that's why I tell people this is some of the best medicine I've ever practiced, because I get to see patients in their natural environment, in their home. I get to customize and individualize their care to them in their home with their family. I get to educate not only the patient, but their family on that care. And I get to do it over time. I'm not rushed in the hospital building. I'm running around patient to patient. I get 5, 10, 15 minutes. Here, I get to zoom in when I want, talk to them, spend time with them, do it at their schedule as well. They want to sleep in, we let them sleep in. I talk to them a little later. As long as it's medically safe to do it, I'll do it. And that ownership in that is what we pass on in that restorative phase. So that at the end of 15, 20, 30 days, whatever that patient requires for their acuity of care, they feel that they've gotten the best care, the best connection, and the best handoff that is possible.
Mike, I got to say, I have to make one personal comment here that I never knew how important coffee was in the morning for our patients and the timing of when coffee needed to occur. It's a huge A, satisfier, and B, delirium preventer. Mary, I've got to ask you a question because this is sort of coming through the chat. And we talked about the clinical care team, both in the, perhaps a centralized fashion, perhaps not, that's coordinating the care, and then the care team in the home. But there's like a whole nother bunch of things happening to make this program possible, which goes to logistics. Mm-hmm. So can you talk a little bit about both, what you need to do to stand a logistics platform up, and then bigger picture, what are the implications, either regionally or nationally, for the supply chain that need to allow this type of thing to scale?
Yeah, we fortunately we have partnered with Medically Home, which is I think of a group that partners with providers to enable that supply chain. They have the technology platform that helps with that supply chain infrastructure and the logistics, and can feed it helps take our orders that we enter as clinicians and turns it into a supply chain request, and really provides that, helps coordinate all those resources to make sure that they're brought to the home, to the patient in a coordinated fashion. So partnering, I think we need that type of vendor that can coordinate all these various entities to help bring all that infrastructure into the home. And certainly we need it to interface with the EMRs that we're using so that it is seamless. And that as you enter an order, it then is, transmitted to the along the supply chain so that it's brought to the patient. So they've been really critical in us being able to scale and set this all up. As we've expanded into new service areas, new geographic areas, it's really critical to make sure that all that infrastructure is in place before you start caring for patients. And that includes things like, intense simulations, making sure that, playing out different scenarios about, a patient now needs IV fluids, patient now needs more frequent labs. Have we practiced for that? Do we know that we have that ability, so that we're not surprised, because, as we all know, patients don't always follow, the clinical care changes, and you have to be ready to respond. But I think, having that close partnership with the supply chain vendor and understanding the logistics goes back to something you said earlier about patients really wanting their coffee in the morning. I think one thing that we've learned is how much patients and their families really appreciate how well we can kind of plan out their day. And they know that, someone's coming into the home at 9 a.m. Meds are due at certain times. Labs are going to come at a certain time. And they can kind of keep living their life around this schedule, so that, I think it helps with that delirium, the deconditioning. They can be up and around in their house, living their lives, interacting with their families and friends, and they know what the schedule is to, for their medical care throughout the day.
Thank you, Mary. Sarita, I got a question for you, because you referenced in your earlier opening comments the continuum of care. And the continuum of care is something that's A, poorly defined, and B, constantly growing. And I want to reference one group of patients that I think were really invisible before, which are residents in care facilities for the elderly. So they're not in skilled care, and yet they're vulnerable and in need of care. What populations like those that live in RCFEs do we need to be thinking about? How do we need to develop greater connection, either literally going into those facilities, or if we can't scale at that level, what does that look like from your perspective in the future?
Yeah, I mean, the continuum of care, you asked that, what when we really talk about it, what do we mean? And it is this, I call it almost like a suite of services that, have connection points throughout. So it the hospital, whether it's hospital in the brick and mortar or hospital in at home. You got skilled nursing facility, which is part of the continuum of care, has defined roles and responsibilities. You have the RCFEs that offer more supports, but are not as acute in their settings. And I think what you're getting at is we need to be, the care needs to be customized to what the individual needs in terms of their clinical care or their social care or behavioral health care. So regardless of whether it's an RCFE, whether it's a skilled nursing facility, whether it's their home, you'll have to adjust or transition accordingly. So for example, it may be that an RCFE could be a temporary area of where somebody could reside, and then eventually could be at home or never get at home, depending on what their situation is. And so when we think about, so I think it's all about the levels of care and the requirements and the criteria that we have to understand about each person's needs across that approach. So for me, the continuum of care, it goes from it's the whole spectrum. And, I've heard this comment, when nursing homes, they're going to go away, we're going to have everything in the home. That's not true. I mean, we know that, for example, that there are going to be certain needs that nursing homes are going to offer. We know that RCFEs are going to have certain requirement things that they're going to offer, assisted living. I mean, there's benefits to that as well. So I think, we are just in this process of, and again, I hate to say this, but we said this before, but, the incentives have to be aligned to offer those type of services based on the level of care. So I think we still have a lot more to learn about these different facilities and how they are incorporated in the continuum.
Mike, I'm going to give you a sort of lightning round here. Where are we going? Where's the future here? I know you're pushing the envelope when it comes to types of patients you're enrolling. What do you think is possible?
I think anything is possible that can be safely protocolized as we build the workforce of the future, as we have these resources in the community that can deliver care quickly, as the technology steps up and we have camera technology and Wi-Fi technology and things that monitor patients non-invasively and can deliver care quickly, then we can protocolize a lot of postoperative care, bone marrow transplant care. Somebody asked about pediatrics. Kids are scared to death of the hospital. My daughter is. Can we do things at home with them? Yes, absolutely. I think you look at this as, and then I think we move away from hospitals, clinics, all these silos, and look at acuity and what is necessary for a building or people together and centralized resources, and what else can be done in the community and at home or whatever we call home. And that may be missions or shelters or nursing homes or all these other places. How do we build into medical communities and have these programs, a centralized chain of resources in the middle of a nursing community or a care community of elderly that are in a coastal community or something? Build that in, have the virtual aspect, the in-person aspect, and integrate this. And I think you'll see a lot of what's done in home hospital also bleed into the physical hospital practice. Virtual hybrid models at bedside nursing in the physical hospital, in the clinic. You might be admitted to the hospital, have a nurse there, and she might be your virtual nurse at home in the future when you move into your home hospital program. All this is kind of blending together in this lattice of virtual technology and physical care. New jobs, scary things for physicians, for nurses, for paramedics, learning the new ways of treating people. But we evolve as medicine together, and we'll do it and we'll figure it out. And people like Dr. Levine and all these others, they're putting together these things. They're just incredible pictures of the future of medicine. And I'm just happy to be a part of it and ride along.
And David, I'm going to give you the last question. I only got 30 seconds for you here. What does training look like for this program? What do we need to be investing in?
Goodness, last word on training. Home hospital, it's really, I feel like it's where the heart is, and the clinicians that come to the home bring an amazing amount of heart with them. And so I think, honestly, we're always looking for clinicians who are malleable, who are generalists, who are patient-centered. And then they need training. Most folks have trained in four walls, or most folks have trained in a home, or most folks have trained in an OR or a nursing home, and they haven't put it all together. And we are asking for people who can put it all together. And so right now, I think a lot of training is local. And I think we do, as a country, and honestly, as an entire world, need to create home hospital fellowships, home hospital rotations for our medical students, our nursing students, our residents, all of our different care modalities, so that people can learn this all the way from the beginning of their learning journey. You know, we have residents in our program, I know others do, and so we're making steps, but we have a long way to go in terms of creating a home-based care pipeline that can truly serve the country as it ages. But I'm very encouraged by what I've seen right now and all the amazing local innovation going on to train these clinicians all over the country.
Well, you know, I knew we were going to take up the whole hour, and you know, it's been an amazing conversation. I want to thank all of our panelists for joining us. I want to thank all of you, our guests, for taking time out of your busy days to participate in this webinar, for the wonderful questions that were coming through. And we will be making this recording available at a later time for everyone to watch. This is truly transformative work. It's an exciting time to be in healthcare, so that we can provide more person-centered, better care for our patients now and into the future. To learn more about Advanced Care at Home, please visit the Advanced Care at Home Coalition website at achcoaltion.com. And thank you all for tuning in.